Let us see the lymphocyte predominant depletion form. This part is in continuous with my previous video, and now we will move to lymphocyte depletion type. See, in this type, as the name itself indicates, there is depletion of lymphocytes, right? That means there are less number of lymphocytes, or there is absence of lymphocyte. We can easily see it is hypocellular, right, compared to other types like mixed cellular types where there are hypercellularity. Even in this nodular sclerosis type, we can see much cellularity, right, even in this type. But here we can see where there are less number of cells. Even sometimes in some states we may not be able to see the cells. This is usually of two variants. One is diffuse fibrotic variant and another one is reticular variant. In diffuse fibrotic variant, there is diffuse fibrosis will be there in the slides or in the lymph node, and there is much less cellularity, and the fibrosis will give the appearance of hyaline material. Okay, and this is about the diffuse fibrotic variant. In reticular variant, we will see there will be some more cellularity compared to this diffuse fibrotic variant. In reticular variant, there is some cellularity which include histiocytes, scanty lymphocytes, and typical Reed-Steinberg cells. I told you in every type of hodgekin lymphoma, there will be some variant of Reed-Steinberg cell, right? Here is also there is this, we can see the Reed-Steinberg cells, large cells. This variant is called pleomorphic Reed-Steinberg cells. These are pleomorphic because the size, the shape and size will be variant, and moreover there will be atypical of nuclei. You can see the nucleus is not normal. It moves towards the neoplastic cells, neoplastic characteristics, and that's the reason why this lymphocyte depletion type has got very poor prognosis. Okay, and this is something about lymphocyte depletion type. Then moving to another type which is there in the WHO classification, that is nodular lymphocytic predominant variant, right? Nodular lymphocytic predominant type. It is there in the WHO classification, right? The second type. And as said, I told you before, this is a form of lymphocyte predominant type. They have been separated because the prognosis is something different, and the cellular markers which are there on these cells and cells present in this nodular lymphocyte predominant type is also different, right? See, the main difference is that in here there will be lymphocytes, predominant lymphocytes as there in the lymphocyte predominant type. Small lymphocytes will be there, and there is also nodularity. Okay, if you take grossly, there will be nodularity will be there, as if it is nodular sclerosis type. Okay, these small lymphocytes which are there in the nodular lymphocyte predominant type, it resembles as if it is lymphocyte predominant type. Whereas nodularity, it resembles the nodular sclerosis type, and moreover, at usually Reed-Steinberg cells, there is the markers are CD15 and CD30, right? But in this, these usual markers are absent. The markers that are there in the Reed-Steinberg cells are CD45, and another one is epithelial membrane antigen. Okay, epithelial membrane antigen marker will be there. This epithelial membrane antigen and CD45, this epithelial membrane antigen is termed as EMA, right? And I told you they are negative for the CD15 and they are positive for CD45 and epithelial membrane antigen. And this has got chronic clinical phase, and there is relapses will be there in this. Okay, relapses will be there, and this may transform into B cell Hodgkin lymphoma. This can transform into B cell non-Hodgkin lymphoma. And these are peculiarities of nodular lymphocyte predominant Hodgkin lymphoma. Then we'll move to clinical features. Clinical features. I told you this is very common in young years, right? 15 to 45 years of age. And then after they are common in after fifth decade, right? And moreover they are more common in males than females. And initially they most often they involve superficial lymph nodes. They often include superficial lymph nodes. Most common is cervical lymph nodes. And these lymph nodes, there will be firm, palpable, painless lymphadenopathy. Palpable, painless, movable lymphadenopathy. They present with palpable, movable lymphadenopathy. They usually have splenomegaly in 50% of patients. Splenomegaly will be there in 50% of patients. And sometimes we can even find hepatomegaly, right? Hepatomegaly, splenomegaly, all these things will be there. And there is constitutional symptoms. These constitutional symptoms will include low grade fever, night sweats, and unexplained weight loss. Unexplained weight loss means 10% of normal. There will be loss of 10% of normal weight. Okay. Then there will be exertion, and there will be malaise, weakness. All these conditions, the symptoms that we find in neoplastic cases, right? All these symptoms will be there. And if you come to lab diagnosis, lab, mainly hematology. First RBC. There will be normochromic normocytic anemia, mild normochromic anemia will be there. And in iron, the iron stores in the bone marrow is normal. They are normal. The iron in the serum, the iron content in the serum will come down, and total iron binding capacity will also come down in the serum. Okay. Bone marrow infiltration will be there. Due to this bone marrow infiltration, there will be failure of bone marrow, and leukoerythroblastic reaction will be there. Okay. Leukoerythroblastic reaction will be there. Means blast will get released into the serum or blood. WBC, there is usually leukemia reaction. If there is any pruritus, then we can find eosinophilia. Okay. In the advanced stages, there will be penia. Okay, there will be leukopenia. But initially there will be leukemia reaction. Leukemia reaction in the sense there is increase in leukocytes, right? Then we'll move to platelet count. Platelet count usually normal or increase. Then moving to ESR, there is increase in ESR. These are the blood findings or hematological finding. And next coming to immunological abnormalities. In immunological abnormalities, there is decrease in the number of T cells. Or these T cells, decrease in T cell, it causes reduction in cell-mediated immunity. Okay, antibody mediated immunity is usually normal until advanced stages. Okay, this is usually normal up to advanced stages. Then coming to staging, how will we stage this? And the staging is done by arbor staining. The method is arbor staging. Here usually we divide into 4 stages. One is 1, 2, 3, 4. See, here we use some letters here. The letters are E, A,